Hello, I'm Christian España Schmidt. Hospital is at Danbury Hospital, and this is Focus Bites. Today we're going to talk about lobar pneumonia. I'm going to present a case, and we're going to discuss it later. So, the case presentation, this is a 56-year-old man who came to your clinic for some back pain, cough, fever of 2 days. The back pain is over the right lower back, and the cough is of yellowish sputum. Before the cough and fever, he presented flu-like symptoms. He states that he has high fevers at home of 102 and was taking Tylenol. Past medical history, he only has hypertension, he's on an ACE inhibitor and hydrochlorothiazide. Social history, he's a non-smoker, no drugs. He's basically independent, lives alone, and his physical examination, well, the heart rate was 102 per minute, the respiratory rate was 18 per minute, temperature was 100.3 Fahrenheit, the SaO2 94% on room air. He looks moderately ill, however not in distress. He's coughing yellowish sputum. The physical examination is unremarkable except for right lower lobe and inspiratory crackles. So in the right lower part of the right lung, he had inspiratory crackles. At that moment, we didn't have labs or X-ray to take it that day, so we need to make a decision. So it seems to be a low-risk patient with a curve 65 that is low. He doesn't even have 65 years old. And at that moment, what would you do? And of course, this is a point-of-care ultrasound case, so we can check the chest of the patient while sitting and check the lungs. So I always would like to start with an 8-zone evaluation of the chest while the patient is supine, and I'm going to explain to you why. This is why if I see multiple abnormalities, then I would think of a clinical radiologic dissociation, making picture more of an atypical picture. So remember, atypical pneumonias present with what we call bronchopneumonia, bilateral infiltrates usually, and we don't hear much. So that causes a radiologic clinical or clinical radiologic dissociation, and that's why these pneumonias are called atypical. The organisms that cause atypical pneumonia are called atypical because they cause atypical pneumonia, which is a clinical scenario. In this case, we did an 8-zone method of the chest, and when doing the AUS, the mark of the probe should be pointing towards the head of the patient, remember? And to evaluate lung disease, you will use a phase array or a curvilinear probe. In the hospital, we have a phase array probe. So this is what we saw in the normal front ultrasound. So we here have a rib, as you can see. We have a rib, so our probe is well positioned between two ribs, and you can see the acoustic shadow after the ribs, and then we can see the pleura here moving normally and A lines. So this was the finding of the whole front ultrasound. So this patient had a normal front ultrasound. So atypical presentations or fibrosis are likely not a contaminant in this case. And then we went to the back and specifically to the right lower side of the patient, and this is what we found. So here you can see a thickened pleura, again a rib with acoustic shadow, a rib and acoustic shadow, and you can see a B-line here, and you can see it moving up and down. Usually we talk at an abnormal quadrant to have at least 3 B lines or more. Here we see 2 B lines, but they are not flickering. Usually B lines from pulmonary edema are very flickering. These ones are not flickering and are from the base of that. You can see the pleura is a little bit thick and different from the prior slide. So here we have another slide, and we can see that there are many B lines. This is from one intercostal space above the other one that I showed you. The pleura is moving fine. However, there are multiple B lines, and as I can see during my experience, these lines are not flickering. Usually the lines from pulmonary edema, cardiogenic pulmonary edema, are flickering lines. I'm gonna show you a case later. And basically at this moment our diagnosis was a right lower lobe pneumonia. We have the x-ray of the patient to demonstrate a lower lobe pneumonia. The patient did not have a pleural effusion. Successfully treated with antibiotics and discharge. So, like this video and subscribe to the channel. I hope you like it. Right now we don't have classes because of coronavirus, so this is a good case to learn a little bit of.